Good morning from the annual meeting in San Diego. We're pleased to be here today with Dr. Naveen Rao. Thank you, Naveen, for being with us this morning.
Thanks for having me.
Naveen, it's an honor to have you because you've become quite the expert in scleral IOL fixation, and I know you have a really cool topic at this meeting about techniques and tips and pearls for scleral fixation of IOLs. Can you walk us through briefly what are some of the more popular techniques now, and what are some important ways in which these techniques have been improved over the course of time?
Well, there's several scleral fixation techniques. There's the tried and tested CZ70BD Prolene suture technique, and some people have recently tried to suture that with Gore-Tex, which works really well, and you get excellent centration. It's a bigger lens. But some of the sutureless techniques, like the glued IOL technique, the flanged haptic technique, which are really popular, partly because they allow a much faster surgery. They don't require the need for sutures, which takes time and is quite intricate. I think these are great techniques. I like personally the flanged haptic technique. I find it to be helpful because it's not requiring the dissection of conjunctiva, and it's much faster than the CZ70 suture techniques. The other technique that's popular, the ASCRS technique, I find it to be a little bit risky in terms of the amount of sutures, amount of sclerostomies that are needed.
Well, I know, Naveen, that you mentioned earlier about a particular study involving the Gore-Tex suture technique versus a flap flange technique. Can you describe that for us, please?
So in our institution, we've been doing a long-term longitudinal study about a comparison of the flanged haptic technique versus the Gore-Tex technique that our retina colleagues have typically been favoring. But I will say that more recently, they've all been switching over to the flanged haptic technique because they're finding the surgeries tend to be faster, there's less complications. In our series, we're finding a higher rate of ocular hypertension, about 50% in the Gore-Tex acrylic sutured lens group versus a rate of ocular hypertension closer to 20 to 25% in the flanged haptic group. Similarly, a rate of CME, post-op CME in the Gore-Tex group of about 30 to 40%, as opposed to about 7 to 10% in the flanged haptic group. So it tends to be better for long-term outcomes as well as for short-term outcomes. There have been some exceptions to that. So for example, I did in the past more glued IOL technique, and I had one patient who had recurrent vitreous hemorrhages who we recently had to switch that patient's lens from a glued lens to a flanged haptic lens technique to help decrease the recurrence of vitreous hemorrhages.
I see. What about, Naveen, what about centration of the IOL? I know that that's been a topic of concern where sometimes if the IOL is not centered or if it's on an angle, it can really affect the visual outcome.
Yeah, so this is a really interesting topic, and there's been a lot of attempts to try to trim the haptics to try and center the lens better. Of course, the problem there is the more you trim one haptic, the more tilt you generate. And so there's some finesse required there. What I found is if the lens is decentered along the axis of the haptics, then trimming one haptic or the other can be accomplished, and that is pretty effective, especially if there's small amounts of decentration. But if the lens is decentered on the other axis, 90 degrees away from the haptic line, then it's not helpful to trim the haptics. To recenter the lens, you'd have to redock one of the haptics by internalizing it and redocking it and re-externalizing it in a different spot. So it depends on which direction it's decentered, whether trimming works or not.
Right. Well, Naveen, we've seen so many modifications and improvements upon these techniques over the last few years. Where do you foresee this realm going in the next few years? Do you think that we're going to have better IOLs or better suturing techniques, better glue techniques, or have we reached our pinnacle in this field?
Well, I think what we really need in the States anyway is a larger diameter lens. If we had the same haptic material, which is my preference is to use the Zeiss lens that has polyvinylidene fluoride haptics, they're much more malleable, then if we had a larger optic, it would be much easier to achieve centration. In Japan, they typically use a 7mm optic, whereas we're dealing with a 6mm optic with essentially a 5mm effective optic with this particular lens. It's harder to get centration. Part of it also requires a better instrument used to mark and to guide the needle passes. I think when we have an instrument that can be effective at that, we'll be able to get better centration right from the get-go, so there won't be as need for trimming. So at the moment, I'm working with an instrument, on an instrument with Mastel that can help improve this, and I think once we have a better finalized design, it will be possible to get better centration.
Well, Naveen, this has been a terrific discussion for us this morning about about scleral fixation techniques for intraocular lenses. Thank you so much for sharing your expertise today. It's been a pleasure, and thank you to our live audience for your support as well.
Thanks for having me.